be live soon.
Good evening, web shadowers, and welcome back to our first session for the fall 2021 semester. We would like to start off by thanking you all for joining us tonight, and we hope you had a great summer. We're very glad to welcome you all back.
Tonight we have the pleasure of hosting Dr. C, who will be teaching us about family medicine tonight.
Pulmonary critical care.
Pulmonary. And as always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. And with that being said, Dr. C, you may start whenever you're ready.
Yeah, thanks for having me back. For those of you guys who do know me, I'm Neena, Dr. C. I'm internal medicine board certified, and I'm in my pulmonary critical care last year fellowship, third year. So we'll be looking for jobs, which is super exciting. So today I am just going to get started. If you guys have any questions, you can ask along the way. I can begin a little bit about what I do. So internal medicine is pretty much everything under the sun for adults. And afterwards, you can do a fellowship in any specialty of your choice that you like. So specifically, I chose pulmonary, which is the study of the lungs, and critical care, ICU medicine, which pretty much is like the sickest of the sick patients. We see patients who are dying, we bring them back to life, like post-cardiac arrests, patients on the ventilators, if they can't breathe for themselves, if they need blood pressure support. So it's the sickest of the sick. Love what I do, and I will actually get started. I hope you all can see my slides. Okay. So we're going to begin with the case. Our first case is a 28-year-old, mild asthma in the past. He comes in for shortness of breath. It's just patient coming into the ER for shortness of breath. Past medical history, none, just the asthma, which he said. Surgical history is appendectomy. Family history is mother with pancreatic cancer, father with some type of lung disease, brother with asthma as well. Social history is marijuana, and then we always ask anything else you'd like to know. More specifically, in these types of patients, I like to know a little bit about their asthma, a little bit more about it, and I also like to know a little bit more when they say social history of just marijuana. How much do you use? When do you use? What type do you use? Especially in the pulmonary side of things, we ask about vaping. That's really important. And then another thing that we ask is it filtered or unfiltered? That's really important to know, because the filtered ones sometimes can take out the particles that are very toxic to the lungs, but usually that's never the best sign. Okay. So what we're going to start with is imaging. So normally when a patient does come with shortness of breath, the things that we always do to start, ABCs. That's the alphabet of critical care, ER, anesthesia, medicine in general. ABC. A is your airway. You always make sure a patient has a protected airway. Make sure that they are breathing. And then B is breathing, of course, to make sure that you're breathing. And then C is circulation. So that deals with your blood pressure. You make sure that they're vitally stable, that they have a heart rate, that their heart rate's not in the 200s, that their blood pressure is not tanking in like 50s over 20s. And this is important because this is blood flow to all your organs. And then besides ABCs in my head, I'm thinking, okay, checklist, what are the vitals? What's the imaging? Imaging is always one of the first things that us as pulmonary ICU, we like to look at. So this, we're going to go over to begin what a normal chest x-ray looks like. So this here is normal. In order to know abnormal, you have to know normal. So looking here, I like to go over a checklist, A, B, C, D, E. In my head, I feel like that makes it easier for me. And I'm sure that can help you guys as well. So going over A, the first thing that we look at is airway. Here, this is the trachea, and the trachea is our central airway, and that connects to our two lobes, the right side and then the left side. And then, so that's the trachea. What you look at in here is, do you see if it's deviated to the right or to the left? This can indicate that there's atelectasis. Atelectasis is, if you think about our lungs like trees, you have your airways and you have your smaller airways like branches, then more branches until they go to leaves. And leaves are gas sacs, and they take in your oxygen when you breathe in, and then they take out your CO2 when you exhale. So there's two processes to breathing. One's inspiration and one's expiration. Inspire, you take in air. Exhale, you breathe out your CO2 or your waste products. So over time, if you don't use your alveoli, you lose them. Or if you have things like pneumonia, acute respiratory distress syndrome, viral infection, bacterial infection, fluid, sometimes that can fill the alveoli. And when that happens, the gas sacs, it becomes this particles, whether it be cells, debris, bacteria, fluid, pus, blood, it gets trapped in these air sacs. And that can shift the trachea or the main airway to the right and to the left. So that's one thing that we look at. So that's a airway trachea. Other things we look at in the trachea are we see if a patient's intubated. So the quickest way to see if the patient's intubated is you look at the chest x-ray. And if you don't see a tube in their airway or in their trachea, then they're not intubated. Other types of airway devices that you can see would be a tracheostomy. A tracheostomy is generally placed in patients that are on the ventilator long term, that we can't get off the ventilator, meaning they can't breathe for themselves. We've been seeing that a lot with COVID, especially. Usually we say 10 to 14 days on the ventilator, and then we start talking about a tracheostomy, which is, it is an airway, but it's just placed lower in the throat. So that's pretty much the major things for A that we look at. For A, airway, we look. And then other things, we said make sure it's not deviated, because then other things that can cause deviation could be a large tumor. So if you have like a mediastinal tumor that can deviate one of the tracheas to the right or to the left. So that's important. And then sometimes if you have a lot of pressure in your heart, that can also make your trachea or one of your main stem bronchi. The main stem bronchi are the two big branches that come from the trachea. So this here is your straight trachea, then you have your right main stem and your left main stem. If your left main stem, it's supposed to go like a triangle. And if they're straight, then that means that you could have a large heart. Your large heart would be like pushing on the two sides, making them straight. So that's another thing that you can look at with A. Chest X-rays can tell you a lot of information if you actually know what to look for or pay a lot of attention. So that's A. Then B would be breathing. And breathing is important because, well, breathing and borders. We'll talk about borders in a minute. But breathing is important because you want to be able to see all your rib shadows, and you want to make sure that there's nothing in between. If there are things like fluid, then you won't be able to so carefully see the rib shadows. And then when you count, you should have about 11 to 12 posterior ones. Even though these look like they're the anterior ones, they're actually the posterior ones because the cage is shaped like that, our rib cage, if you think about it. So the anterior ones look like they're the posterior, and the posterior ones look like they're the anterior. So you look to see about 10 rib shadows, and that would tell you that it's a good film. And then usually we like it on end expiration for our films. So that would be B for the breathing part. Then also B would be borders. And borders are important to look at because they can tell you if a patient has fluid, they can tell you if a patient has a pneumonia. And specifically for the borders that we look at, it would be the C, the costophrenic angles here, which can also go with C. Here, if you can clearly see this demarcation here and that triangular shape form. If you don't see that triangular shape form, then that can indicate that there's fluid. Fluid likes to be in the dependent area, so where gravity deposits is where fluid likes to sit, which is here and here as well. So if those are obscured or you don't see them so clearly defined, then we say that there's fluid. So that's B. Other things for B for borders would be the heart. So their heart should usually be 1/3 to the right and 2/3 to the left. That's our general rule of thumb. And it should be less than 50% of the hemithorax itself. So if you see here, this is less than 50% of the hemithorax, or the whole thorax in general. And that's important because if it's larger, then that would mean that you have cardiomegaly, heart failure, because the heart's just getting bigger and bigger. Remember, the heart's a muscle, just like your own muscles. If you work out, they get bigger, just like the heart. The heart keeps pumping, pumping, pumping. It's working harder and harder and harder. It's going to get bigger and bigger and bigger. So that's important. So that's for B. For C, what we look at, C would be cardiac. So C for the cardiac, it would be the heart, which we kind of just spoke about. Also for C, another thing that we look at is the border. So here is the right border. You kind of see it that it has that little curve here, and that's important. Because if that's not curved, if it's more like straight like that or straight like this way, then that can indicate that there's high pressure on the right side, which can tell you that the patient might have right heart failure, higher pressures on the right side, whether it be due to left-sided heart disease, whether it be due to some type of underlying lung disease, prior blood clots in the lungs. So you look to see that this is curved here. Then you also look to see the AP, or the anterior posterior window here. That's important because if that area is full, then that can also say, or you can also kind of tell you that they might have higher pressures in the right side as well, because all that backflow usually goes back into the pulmonary capillaries, and then that's that area that likes to accumulate the fluid here, the AP window. So that's for C, and then D would be the diaphragm. So just quickly recapping what we spoke about, we're looking at a normal chest x-ray. A is airway. So you look in the trachea, you look to make sure that the right side, left side is not deviated. B is breathing. You count the number of ribs. Usually expect to see 10 to 11. Then B is also the borders and the cosophrenic angles. C would be the heart. You look to make sure that it's not super big, that it's not greater than 50% of the thorax. 1/3 to the right, 2/3 to the left. And then now we're on D. So D is your diaphragm. The right is always more elevated than the left in normal people if you don't have a congenital hernia or a diaphragm defect. And this is because the liver is on the right side, so that kind of pushes the diaphragm up. And then so you can kind of see that here, that the right side is slightly elevated compared to the left. Usually they say that it's a rib shadow elevation. Now, in people that have underlying lung diseases like COPD, chronic obstructive pulmonary disorder, it's an airway problem of obstruction, chronic obstructive. So in that case, they have a problem exhaling all their air. Remember, we spoke about breathing. There's two parts to it. One is inhalation and one is exhalation. These people, when they try to exhale, they can't fully exhale. So what happens over time is they trap air. They trap air and air and air because they can't exhale. Their airways close on themselves. So you'll see in them that they have a straight diaphragm. They don't have this elevation here. And because they have a straight diaphragm, they have to work harder to exhale. So that's why they always look like they're huffing and puffing, usually when you do see end-stage COPD or pretty bad COPD disease. Other things are, if your left side was more elevated than your right, that could be due to a surgical defect. If you had a CABG, which is cardiopulmonary bypass, 4-vessel disease, or if you had surgery in your cervical area, that can also cause an elevation of your right. And that's really important to know, because that can affect breathing, that can affect your respiratory status. So that's important. So that's D. Also, another thing that we do look at to see if there's air under the diaphragm. If there's air under the diaphragm, that's a surgical emergency, and that's usually a gastric perforation. So here you can see that it's completely white, that there's no black parts under the diaphragm. So that's a good thing. So that would be our D. And then E is extras. Extras would be any lines that the person has, or anything extra, like a pacemaker or an AICD that you can see in their chest wall. Here, the patient doesn't have anything, but usually what I'm used to looking at would be like a central line, a hemodialysis line, maybe an AICD. So that would be the extra. So you have your A, B, C, D, E's. That's usually what I go through when I'm doing my checklist of just quickly eyeing a chest x-ray. That's the checklist that goes through my mind. All right, so getting back to our case, we have a 28-year-old who comes in with shortness of breath. This was the beginning chest x-ray. The patient tests positive for COVID, so requires nasal cannula, then ends up on high flow nasal cannula, and then gets intubated, and then becomes positive for COVID ARDS. So what are we talking about when we say nasal cannula and then high flow cannula before intubation? So nasal cannula, it's important to know oxygen delivery systems, because each of them can deliver a certain amount of FiO2 and a certain amount of flow. So FiO2, our ambient room air that we're breathing now, is 21%. 4% over would be the 1 liter nasal cannula, and then 8% over 21% would be 2 liters, and therefore, and there's such. So flows, if you're going from anywhere from 1 to 6 liters, that's your typical nasal cannula that you always see on like shows, medical shows, Grey's Anatomy, which I love to watch, Chicago Med, all those great shows. That's your typical nasal cannula that has up to 6 liters flow, and FiO2 can go up to 40%. Afterwards, we move on to a non-rebreather. So that's like a triangular piece here. It's called the face mask. And then that can give you up to 10-liter flow. So it starts at 5 and then goes to 10. Why is flow important? Flow is important because when a patient's short of breath, they're huffing and puffing. They're breathing very quickly because they're trying to take in a deep breath, but they're not able to. So they just keep inhaling, exhaling, really shallow breaths. So that's why putting on something like the face mask or the Venturi mask, we find it a lot easier on patients. So these are the next two that we go to after nasal cannula. Face tense, we don't do too much, but then we go into non-rebreather. So non-rebreather, up to non-rebreather, we keep patients on the floor or ER. Anything above non-rebreather, we take to our ICU, our intensive care unit. So non-rebreather can go up to 15 liters flow, and it has up to 90% FiO2. And a non-rebreather looks like this. So it's kind of like this, but it also has a bag underneath it. And what non-rebreather means is your CO2. When we talked about breathing, we said you inhale O2 and then you exhale CO2. So a non-rebreather has this bag here and it has holes on the side. And essentially when you breathe out, it leaves that little mask area, your CO2 leaves. So you're not rebreathing your own CO2. And that's non-rebreather. So you're not rebreathing your own CO2 because it has the little holes on the sides of that the rectangular mask shape on your face. So once you exceed 15-liter flow, meaning you're still desatting, your oxygen saturation on the vitals is still going low, like 88, 87, then we'll put you up to a high flow nasal cannula. A high flow nasal cannula, this and BiPAP and CPAP are non-invasive ventilations. They're types of devices that have really saved a lot of patients from getting intubated during COVID time. And just in general with severe respiratory failure, they have really helped a lot of patients to not end up on the vent. And it's been great to have these. A high flow nasal cannula, it's pretty much like a nasal cannula. It is a nasal cannula. It just delivers a higher flow of oxygen. The flow is humidified. It can go really higher flows. It's a lot more comfortable for patients compared to a BiPAP or a CPAP that's like on their face sitting like that. A lot of people get frustrated with that. So high flows have been good. And this can go up to 100% FiO2. So these are the different oxygen delivery systems. So our little patient, he tested positive. He ended up on a nasal cannula, and then he went to a non-rebreather, and then he went to high flow. And then we saw this chest x-ray, and then his chest x-ray suddenly looked like this. Oh no, you barely see any aeration here. Here, basically, what you do see is a bunch of junk. Like where's the lungs? So first things first, right? Airway. So you look at the airway here, you see something in there. Looks like patient got intubated. So you see that airway here. It's like a straight little line that's going there. And then you see that right, and then you see the left, which if you can see, there's really so much what we call ground glass opacities, infiltrate happening all over the lungs that there's not much black in these, in what you're seeing, and black is air. So there's clearly not much air going through this patient's chest x-ray. Heart looks big. You can see it more on the left compared to the right. And it looks like a poor inspiratory effort, but also looks like patient can't take too much of an effort. All right, so this, like we did say, it's COVID. These are some of the labs that we do check. CK, ferritin, dimer, all of this patients was high. A little bit about COVID. It's spread through droplet particles, sneezing, coughing. It enters through the nose, eyes, mouth, which is why we say cover your eyes, cover your nose, and cover your mouth. Once it enters the SARS-CoV-2 virus particles, it's an RNA virus. It enters into our cells. Our cells then take the viral the cell's RNA, and then our own cells take it and then re-replicate that and then produce new particles and spread them into our body, into our system, into our hematologic system, going into all of our major organs, including our lungs, which is what we are going to get into today. So once it enters into our lungs, it basically forms what we call acute respiratory distress syndrome, ARDS. And that's going to be the focus of our talk today. What is ARDS? How do we define it? How do we treat it? So acute respiratory distress syndrome. This is when the lungs are essentially primed by some type of something that causes the lungs to go into its own cytokine storm, if you may. It can be because of things like aspiration. It can be a pneumonia, whether it be bacterial, infectious, fungal, viral. It could, or COVID even. It could be due to pancreatitis. It could be due to many different things, ARDS. And essentially, there's a Berlin criteria of specific criteria in order to define ARDS. So one is timing of onset. Usually we say it can be up to 14 days. And the imaging has to have bilateral, meaning both sides, your right and your left side, have to have infiltrates, we call them, bilateral ground glass opacities or infiltrates. So timing is important, the imaging is important, and then the PaO2 to FiO2 ratio is very important as well. This basically means, this kind of defines the severity of ARDS, whether you're under 200, under 150, or under 300, and this will tell you how severe the ARDS is. And then you also, in order to also define the criteria for ARDS, it has to be not cardiogenic is one of the other criteria. So it's important to know ARDS because it is very severe to our lungs and very detrimental. So essentially, this is what we see in ARDS. You see here that they're black, like we said, was air. This is a CAT scan of the lungs, a CT. A CT is different than a chest X-ray because it cuts from above. So a patient goes into like a tunnel-like thing and it's cuts from above, and they're thinner slices. And then you see more resolution on them so you can see the vessels. So here you see all this white stuff. You see all this white stuff. And you're wondering, what is that? Well, no, that's not supposed to be there. It's supposed to be black because black is air. So this is the ground glass opacities, and that's filling up the lungs. So what happens when the lungs fill up with this stuff, you can't oxygenate as appropriately as you normally would if your lungs were not filled with this consolidation or this ground glass opacity. So essentially you're working with only half a lung, or what we essentially refer to as baby lung. So in ARDS, the term baby lung has been coined. And the reason that is coined is because there's only a part of the lung that's functioning, and it's not a lot. So our goal in ARDS, acute respiratory distress syndrome, is to be able to oxygenate and to ventilate the small portion of the lung without causing too much damage. Because normally when we do oxygenate a normal person, we oxygenate the normal lung, the whole lung. But if you try to oxygenate the small lung like you would a normal lung, you can get a lot of complications. So we talked about a little bit about what it is, the timing of onset, what to look for, how to define it. A little bit more about the pathophys behind it. We spoke about our lungs kind of being like trees. So you can see here, you have your trachea, you have your right, and you have your left. So you have your branches, and you have your smaller branches, and then you have your leaves, or your alveoli, is like we call them, which are important for gas exchange. Here is a normal alveoli. This is how a normal alveoli looks. You'll learn about goblet cells. That's what's lined here. The pseudostratified, columnar, epithelial cells. And what's important here is to see that you have cells, your normal working lung cells. Type 1 and type 2 pneumocytes. Pneumo is lung, cyte is cell. So you have two different major types of cells that work in a normal, healthy alveoli, or healthy gas exchange leaf, if you may. And those are important for secreting certain factors that help keep it open, that help keep the red blood cells oxygenated. Because with each area, or each alveoli, each little leaf, there's a blood vessel that's right under it, connected to it, because the blood vessels carry our red blood cells, and the red blood cells get its oxygen from the alveoli or the leaves, and then it travels to the rest of the body. So once you breathe in air, all that oxygen as you breathe in goes into your alveoli and then deposits onto the red blood cells. Now, if you look at here, an injured alveolus, the normal cells aren't working as efficiently as they would be in a healthy alveolus. In fact, there's so many cytokines going on in here. You see IL-1, IL-6, IL-8, TNF-alpha, activated neutrophils, proteinases. You see all these cellular debris. So all these are lining this alveoli that's preventing that oxygen from leaving the alveoli to get to the red blood cell to travel through the bloodstream. So essentially your red blood cells are not giving as adequate oxygen to the rest of your body like it should. That's why you see desaturations, meaning when you put on the oxygen saturation, you see it's going down and down. You see it in like 88, 86, 85. And that's scary because then you're not oxygenating your brain, you're not oxygenating your kidney, you're not oxygenating your liver, you're not oxygenating your heart, you're not oxygenating pretty much anything. So it's very critical that we keep our oxygen saturations normal. This is essentially what happens in ARDS and also in COVID, because COVID is a type of ARDS. And this is what we try to stop. And the way that we try to stop it, we'll talk about now. So this is another example actually of a real patient, chest x-ray from COVID. You could see here that you can't see anything. It's all white. So there's no oxygenation happening here. And then here, this is a CAT scan, and it's actually a pretty CAT scan, but not good for the patient. It's full of white patchy infiltrates, ground glass opacities, clear ARDS, a ton of white stuff. You can't see much black. That's scary. Sometimes when this does happen to some patients, some people, if it's so bad that we can't oxygenate them, we put them on bypass, pulmonary bypass. That means that we hook them up to lungs outside of their body. So it's called a VV ECMO, extracorporeal membrane oxygenation. So essentially, it's a big catheter that takes all of the patient's deoxygenated blood. It has its own oxygenator, gives the red blood cells in that little container. It'll take the deoxygenated blood, get oxygen outside the body, and then exchange. Another catheter will be going from that little box to the body and giving that oxygenated blood. Essentially, it bypasses the lungs and gives the lungs a chance to rest. And this is important because there's just so much inflammation, so many cytokines being released. Not much oxygen is leaving the alveoli, and so the body is not getting oxygenated. So giving the lungs a chance to rest, essentially, and treating them with whatever you're going to use to treat helps in a lot of people. So our treatments for ARDS, normally what we do is lung rest. So lung rest is very important. Your lungs just need time when they're in acute respiratory distress syndrome. We give steroids, and steroids have been pretty extensively studied. A lot of studies have shown benefit, but some have shown no benefit. Specifically for COVID ARDS, it shows great benefit. And the reason for that is because COVID is full of cytokines. It's full of a cytokine release, and that decreasing the inflammation, decreasing all those cytokines, stop all those interleukins, all these particles, all these inflammatory reactive processes from being released and damaging the alveoli. So that's specifically for COVID. For other ARDS causes, whether it be aspiration, pancreatitis, other types of bacterial infection, ARDS, steroids is not too helpful in those cases. What we do is we like to keep the lungs dry. So we try to avoid too much fluid in them. So we'll give them a medication that will help them pee to keep their lungs a little on the drier side. Then we make them relax. We usually intubate these patients. So you end up going from nasal cannula, non-rebreather, high flow, maybe BiPAP, into the mechanical ventilator. So that looks like a patient will be intubated. They'll have a tube into their mouth, and then they'll be hooked up to the mechanical ventilator. And then we completely sedate them, meaning they don't remember anything that's going on. And then we also give them an analgesic for pain, because anything that's in someone's mouth, if you feel it, it's going to be frustrating. You're going to stimulate your gag reflex and want to throw it up. Or instinctively, you're going to want to reach your hand and pull for the tube. That's almost anyone's human reflex to pull for. So we put them on sedation. And then sometimes other things that have been helped or have helped in ARDS is paralysis. So paralyzing somebody means that you completely sedate them, you give them an analgesic, and then you put them on a muscle relaxant. And this helps the muscles, and specifically the muscles in the lungs and the external accessory muscles around the lungs, like the diaphragm, the intercostals, all the muscles that are involved in inhalation, exhalation. It helps them give a rest. This is important because any type of movement will cause the stimulation of the inflammation. Essentially, you're trying to give the lungs a rest. And you do that through various modes. So those are mainly our treatments to date of what we do besides random things on the ventilator. We do high PEEP. PEEP is positive end expiratory pressure. You'll see that on the vent. And that specifically helps because it keeps all the alveoli open. So all these alveoli stay open through PEEP. So that's something that's super important. And then, yeah, there's a few other recruitment maneuvers that we do on the ventilator. But so that's a little bit about ARDS. And this slide here, I like it because it talks about what COVID does. It affects every system in our body from our head to our toe. So get vaccinated. All right, so our second thing we're going to talk about today is shock. So essentially, what is shock? Besides somebody being super shocked. So there's 4 major types of shock. Essentially, shock is a life-threatening condition causing inadequate blood flow to a specific organ, specific tissues of an organ, specific cells of an organ. So it is, let's say the heart isn't getting any blood, and blood is important because blood carries oxygen. Then that would cause the heart to stop. If your brain isn't getting any oxygen through red blood cells or just in general, that would cause the brain to seize or to just stop, and then that would be a stroke or seizure. So it's complex, it's life-threatening, and it's usually more than just one organ failure. So you can see here that there are 4 major types: hypovolemic, cardiogenic, obstructive, and distributive. And then we're going to briefly go over each one today. So hypovolemic. Hypovolemic is pretty much as easy as it sounds. Hypo is low, volume is, volume. So if you're low in volume, if you're low in blood, if you're low just in your body fluid in general. Now this could be through hemorrhage. That's usually the number one cause. Hemorrhage, meaning someone's having a severe GI bleed. They're just vomiting blood out through an ulcer that's perforated, an artery in their stomach that's perforated. They just went through surgery and they had a nicked artery, then there's vomiting. Or it can be from below. So people can have gastrointestinal, what we call GI bleeds, where they're just pooping blood. We see that in patients that are alcoholics. We see that in patients that have had a lot of NSAIDs that take a lot. That's through ulcer mechanism. So yeah, also other causes of hypovolemic shock could be if you're just not drinking a lot of water and you're just extremely dehydrated. So drink your water, guys. Drink water, important. Or if someone's having a lot of diarrhea, sometimes that can do it. So what you see is it's too little blood volume. And that causes a decrease in blood pressure because, there's just nothing to move around. If you have nothing, how are you going to move it around? If you have no blood to give, how are you going to move it around? So yes, that's hypovolemia. If you don't have any blood, then you're not going to get anything back to your heart to recirculate out. You're going to have decreased venous return, decreased preload. Preload is the blood that goes back into your right side to go into your left side to go out to your body. So you have decreased preload, you have decreased cardiac output, you have decreased blood leaving your heart. And then that puts you hypotension, which is low blood pressure. If you have low blood pressure, then that causes perfusion failure and tissue hypoxia. Like we spoke about, your organs are not being perfused, organ dysfunction, and then multi-organ failure. It's a vicious cycle. The treatment for this is give blood. If you're hemorrhaging, you give blood. You give massive transfusion protocol is what we call it. If you're super dehydrated from having a lot of bowel movements, like nonstop diarrhea from a virus or bad food that you ate, then you just give fluids, IV fluids, a lot of resuscitation. So that's the first type of shock. The second type of shock is cardiogenic shock. So this is essentially that's just your heart not pumping out blood. Because in order to pump blood, you need a heart to pump the blood. So this can happen after someone has a heart attack. After a heart attack, the heart is very weak. And so if the heart's weak, it's not going to pump forward. Other things that can cause it if somebody has an arrhythmia, the ventricle isn't pumping as efficiently as it should. The heart not pumping efficiently, essentially nothing is going forward. And that's cardiogenic shock. So it's reduced cardiac output, but your wedge is increased. And what that means is you have the right side, which gets all the blood back. The deoxygenated side is what we call it. The deoxygenated, and that's the blue. So from the right, the blood goes into the pulmonary capillary wedge, which we spoke about is like the trees, and then that's where it picks up its oxygen from the alveoli. The vessels are under the alveoli. So you have your alveoli here, and then you have blood vessels here, and that's where the oxygen diffuses through, and these are the capillaries that it diffuses through and goes into the left side oxygenated. And that's the red. So it goes from deoxygenated from the right, it goes into your capillaries, which are the arteries under the alveoli, picks up the oxygen, and then it goes to your left side. And then from your left side, it goes forward. Now, if your heart isn't pumping efficiently, all that blood from the left side is going to back up into the capillary circulation, the pulmonary capillary circulation. That's what we call pulmonary capillary wedge pressure, and that's going to be high. It's going to be high because it can't go forward since the heart isn't pumping to let it go forward. It's going to backflow. The CVP and right atrial pressure. So the right atrial pressure is here, and your central venous pressure is essentially your right atrial pressure. And essentially it's the same pathophys because it's not going forward, it's going to go back. Your blood pressure is going to be low because your heart isn't pumping forward. And because of that, certain mechanisms and different hormones will interplay to make your systemic vascular resistance high, meaning your arteries will constrict itself to preserve blood flow. So we spoke a little bit about hypovolemic shock and a little bit about cardiogenic shock. Our next shock is going to be distributive. So that's the fourth type of major shock. There's 4 major shocks that we deal with. So distributive shock is essentially when the vascular tone, or if you think about our body, it's made up of a bunch of blood vessels, it's made up of veins, and it's made up of lymphatics. Lymphatics are what drains all the extracellular blood flow, extracellular debris is what we call it, back is called the lymphs. So you have your arteries and your veins. Now, when when you're in distributive shock, the arteries get big. So if your arteries are getting big, they're what we call vasodilated. And then if they're vasodilated, then it's causing a decreased preload, meaning if your arteries are all vasodilated in your arms, your blood volume is going to want to stay in your periphery. It's going to want to stay all over, and it's not going to want to go back to the heart. Sepsis can do this. Sepsis can do this because sepsis is an infection, essentially. And this is an infection that's causing your body to work a lot. So sepsis is causing your body to work a lot, and that's going to cause a lot of hormones to be released, and that's going to make all your blood vessels be big and dilated. And because they're big and dilated and all the blood is trying to go out to all your cells, since your cells are working overtime because of the sepsis, it's not going to want to go back to your heart to re-come out. And that's going to cause low blood pressure, because there's nothing going back to go back out. The other big one is anaphylaxis. So anaphylaxis is, when you see people that are allergic to something, like people who have peanut allergies, people that are allergic to influenza vaccines, people that are allergic to drugs, meds, pollen, this, that. If somebody goes into anaphylactic shock, that's when their airway closes up, and then they can't breathe, essentially. So that's when they would get intubated and come to us in the ICU. But anaphylaxis is a type of distributive shock because anaphylaxis, or essentially when someone's allergic to something, it's mediated by a histamine release or a cytokine release of IgE, eosinophils, a lot of different agents that are introduced, that are in the body, and they come in excess, like histamine, mast cells. All this causes a lot of dilation, and that can then cause decreased vascular tone, meaning more vasodilation, essentially. So that's anaphylaxis, and essentially that's distributive shock. So here it's a vessel abnormality that leads to dangerously low blood pressures. That's a normal artery, and this is when the artery is dilated. You can see that it's open almost 2 times that size, so it can hold more blood to have come through that artery compared to a normal size. And that's distributive shock. So we spoke about hypovolemic, we spoke about cardiogenic, we spoke about distributive, and then our last type of shock is obstructive shock. So obstructive shock is just like it sounds, it's obstructive. It could be indirect pump failure. Your pump is your heart. So it can be something pushing against your heart that's not allowing it to flow. Whether this is something like cardiac tamponade. Cardiac tamponade is when you have fluid around your heart, and that could be due to cancers, that could be due to some type of virus, that could be due to some type of infection you have going on. It could be idiopathic, it could be after MI. COVID could do it. Essentially what happens is fluid goes around the heart, and then the heart's trying to pump, but it can't because there's, it's restricted. So that's an example of obstructive shock. Another example would be pulmonary embolus. So this is when a blood clot is blocking all the blood from flowing forward. We spoke about in general how blood vessels are under the alveoli, and then blood goes from deoxygenated to oxygenated. And the way that it goes from deoxygenated to oxygenated is it uses the heart. So you have your deoxygenated blood in your right heart, and then it goes up through your pulmonary circulation, and then it goes to your left side after it gets the oxygen in your lungs. And we said in your lungs, you have your alveolus, and then your alveolus, under it has the blood vessels. Your alveolus takes the oxygen and then deposits it into your red blood cells that are in that artery under your alveolus. So alveolus takes the oxygen and then it deposits it in your red blood cells that are under. Now, if you have something that's blocking off the blood from moving forward, that's blocking it in the arteries itself and the pulmonary artery capillaries, like a blood clot, then that's called obstructive shock. And the things that we see there doing that would be pulmonary embolus. So essentially, we said a couple things with the heart. Heart is trying to pump against the high afterload. Afterload is what we call it when we have preload and then we have afterload. Preload is the deoxygenated that's coming back into the heart. Afterload is trying to unload after. And if you have a lot of fluid around your heart, then that will cause a high afterload. So yeah, so those are the 4 important types of shocks that I deal with every day in the ICU. What we do is we try to figure out what type of shock it is. Now, this isn't always black and white. Sometimes it's 2 types of shock. You can have cardiogenic and you can have distributive, meaning somebody could be in severe septic shock from a overwhelming bacterial infection, along with having a heart attack, along with having cardiogenic shock. Somebody could be hypovolemic and cardiogenic at the same time. So it's not always clear cut, black and white. It's a lot of investigative methods to see, because a lot of them sometimes look alike. This here is another example of what we spoke about. Now, it always comes down to what's normal, so you know what's abnormal. Here is normal. You have, like we said, your deoxygenated blood goes in through your superior vena cava, your inferior vena cava, from your up and your below go into your right atrium. From your right atrium, it goes into your right ventricle. Then from your right ventricle, it goes into your pulmonary artery, then into your pulmonary circulation. And in your pulmonary circulations, when it gets oxygenated, then it goes into your left side. Here in cardiogenic, we spoke about it being a part problem with pumping, so it gets a backflow. So you can see the heart's bigger, and this is bigger as well. Hypovolemic is small because you have nothing going into your circulation. Everything is, it's either bleeding or you just have nothing in your pump. Distributive is when it's too much in your peripheries, when it's too much in your circulation and nothing is going back because all your arteries are so wide. And then obstructive, we spoke about there's fluid around the heart you can see, or you have a big blood clot right there. And that's something obstructing the blood from moving forward, whether it be around the heart or around the lungs. Because if it's not the heart, it's the lungs. If it's not the lungs, it's the heart. That's what we always like to say. So a little bit about what we spoke about today in terms of breathing. So when you breathe in oxygen. When you breathe out, you breathe out CO2. Breathe in O2, breathe out CO2. Inhalation, exhalation. Now, why is this important? This is important because there are 2 different types of respiratory failure. When we say respiratory failure, we're talking about breathing difficulty. Respiratory, the lungs, failure. So there's a problem with breathing. Now, a lot of my residents, a lot of my med students, when they rotate with me, they'll say, yeah, this patient's short of breath. I don't know why. And I'll say, okay, well, let's start here. Is it type 1 or is it type 2? Meaning, is it a problem of ventilation or is it a problem of oxygenation? Oxygenation would be if they have problems breathing in, ventilation would be if they have problems breathing out. Now, it sounds easy, but differentiating the two is super important. When you're looking at things that are, because when you're looking at things that will define both of them, if your oxygen, meaning your PaO2, which is your arterial oxygen saturation, if that's on the lower side, partial pressure of oxygen saturation, if that's low, then we say that's usually a hypoxemic respiratory failure. And that has to do with type 1, essentially, with oxygen, pure oxygen. Then there is the hypercapnic. And the way we look at this is we'll do a blood gas and then look at the CO2 level in the blood. And if the CO2 level is elevated on the higher side, then we say that this is a type 2 respiratory failure or hypercapnic respiratory failure, essentially. And it's very important to differentiate because the treatments of both of them are different. So with CO2 being a problem, we use a different type of mask to help them ventilate, compared to if it's hypoxemic respiratory failure, which goes back into those modes of oxygen we spoke about: nasal cannula, non-rebreather, high flow, and intubation, essentially. So this was kind of a brief overview of what I do on a daily basis, the major things that I see, whether it's respiratory failure, whether it's ARDS, whether it's shock. Those are the two most common things in the ICU. One is shock, and then one is respiratory failure. Respiratory failure, be it from hypoxemic or hypercapnic or ARDS, a simple pneumonia, asthma exacerbation, XYZ, the list goes on. But that's really important. And then shocks are very important because the treatment is what puts someone in the ICU, essentially. They're super vitally unstable with low blood pressures. They're losing organ perfusion. They're losing perfusion, blood, oxygenation to their major organs. And that's what I take care of. So this here is an example. This is not a real patient. I found this on the internet, but it's interesting because when I go into a patient's room, this is essentially what I see. This is a ventilator here. The patient is hooked up. You can see the breathing tube right there. And you can see all these pumps. Now, what's important when I always tell my students, all my residents, I try to teach this to anyone, a lot of nurses even, I teach this. The minute you walk into a patient's room, you've started your physical exam because you start and you see what's hooked up. It's always so easy to just chart review and then read about what happened rather than going into a patient's room, because physical exam is a lost art today. Even going in bedside and looking at the drips, looking at this, what is each one running at? One's at 2 mg per kg, one is at 4 mg per kg. These are important implications because if they're running too high or too low, that can really affect the patient's blood pressure, can affect the patient's labs, XYZ. Also, this is important because you see what's hooked up to them. You see a Foley catheter here. You see SCDs, which are sequential compression devices. They help for blood clots. And then each line is important in these patients. And then you see the tubes here, and then you kind of assess the ventilator from there. Well, I'm going to take questions now, and I'm going to thank you all for your time. This is always my favorite quote: "A journey of 1,000 miles begins with a single step." This is not my Instagram. I'm actually Means MD. That's my email address. That's my Insta, and then that's my website. If you guys have any questions, I will be happy to answer them on anything that I said or anything specific to pulmonary critical care. I will definitely be happy to answer them.
Thank you so much, Dr. C. We've sent in some questions in the chat box.
Okay, yeah, I actually do see them. How would one not use their alveoli? That's a great question. If you don't use your alveoli, you lose them. You lose them, meaning you lose the air out of them and they won't expand. If they don't expand, then what happens is we call atelectasis. So if the way that you don't use them would be if somebody is bedbound, like paraplegia or quadriplegia. If somebody cannot move, then they need physical therapy. So you need to continue to use your respiratory muscles. You need to continue to breathe in, breathe out. After surgery, we give patients what we call incentive spirometers. Incentive spirometers are They're about the size of my hand, and they're a little device that has certain tidal volumes inside them. And then there's like a straw attached and a blue ball. We have people breathe in, suck, 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 so they can move their diaphragm and get all those alveoli oxygenated. And that's important to keep them open, to stent them open so you don't develop atelectasis. Does this type of ARDS occur with the flu or other typical flu viruses? Yes. Yeah, this ARDS does occur with the flu, influenza, and other typical flu-like viruses, rhinovirus, etc. It can. Usually it's not a direct cause of the flu specifically or a rhinovirus. It's a secondary bacterial infection that's superimposed on the flu. It's never the flu that people worried about. It's always the staphylococcus bacterial pneumonia after the flu that people are worried about. During distributive shock, when the vessels dilate, do they fill up with air, or is there just negative pressure within the vessels? They don't fill up with air in distributive shock. It's more of a cytokine release or hormonal release that causes the blood vessels to stay open. They just fill up with blood, and that's why your blood pressure is so low, because they're filled up with blood. And also there's a lot of capillary edema, so you lose the hydrostatic oncotic pressure that allows your third space to be your third space, and then you get a lot of leakage around. Any other questions? All right. Someone's asking to view your contact again. Oh, okay. Okay, guys, so this is my contact. This is my email address, my Insta, and my website. My advice to all of you, if you have not been vaccinated, get vaccinated. Everyone you know should be vaccinated. We're starting to see a rise in cases again. It's not a good thing. It's scary, and I have seen so many young people just get very, very, very severely sick because of COVID. So take care, take precautions.
Thank you so much, Dr. C, for presenting to our web shadowers again. It's always an honor to have you and learn from you. And you always make your presentations interesting. So thank you very much.
Thank you guys for having me.
Everyone, make sure you check out her socials. Her Instagram is NeenZMD.
Thank you, guys.
I have just posted the Google form link in the chat. So everyone, please fill it out within the next 30 minutes for us to receive your attendance. And again, thank you so much for another great presentation.
Thank you, guys. Have a good night.